Santosh, any delegates? You called them up? Santosh, are you there?
Sir,
Sir,
he's
he's not.
joining, sir. Yes, he's joining, and we are starting, sir, because Dr. Chandrasekhar has got some emergency.
Okay, okay.
And yes, and Dr. Vijay Prasad, he's joining soon. He said, within just 5-10 minutes, he'll be joining, but he's getting
Okay.
some internet error, sir.
Okay,
Okay, so
okay. The
meanwhile, sir,
glitch.
we will start, sir.
Okay, okay.
Yeah. Santosh is joining, sir.
Okay, okay, okay. When you're ready, you tell me some.
Right, sir? Yeah.
Okay, okay. Since lockdown, many people are working from home. So I asked my person, one of my friends, engineering friend, what are you doing? He says, no, sir, I'm working. I'm not working from home. I'm working at home also. Helping his wife in kitchen. The other one said, I think you must be knowing that there are only two things now in this present lockdown, in this present scenario. One is corona, another is Sonora. Huh? That means Sunoji, wife says the husband has to listen now. Oh,
Yeah, sir. Other 1 minute, sir. Vijay Kumar is going to join.
okay,
And Chandrasekhar is also going to join, sir. Meanwhile, sir, we'll start because all participants are waiting.
okay, okay, okay,
So, not to wait, sir. Yeah, Swati
okay.
ma'am, please, can you please start, ma'am?
Right. Mr. Amrish,
Yeah, yeah.
we
Just
are
give me
we are
next
live
30
now.
seconds. Give me 30 seconds.
Yeah.
Yeah, we are live now. Over to you.
Yeah, we are live, no?
Yeah, yeah.
Yeah. Thank you so much. On behalf of Alkem Laboratories, India's fifth largest pharma company, I, Swati Pawar, welcome our eminent doctors who have joined us for today's panel discussion titled Galaxy of Experience on Rosuvastatin. At Alkem, it has always been our endeavor to partner with a healthcare professional, and we will continue to do so even in these challenging times. To help us navigate through the meetings, we have with us today Dr. D. Ramesh, who will be our moderator for today's panel discussion. We take this opportunity to welcome moderator of the day, Dr. D. Ramesh.
Thank you.
And Dr. D. Ramesh is a renowned and eminent cardiologist in Bangalore. Also, I would like to introduce to you a galaxy of panelists, Dr. Uh, Dr. Sandeep Putta Manohar, who is a well-known endocrinologist in the city and a very and having a vast experience in the endocrinologist field. So. And we have over here Dr. Suman Ramchandra, who is the eminent diabetologist and consultant physician in Bangalore. So here we have a galaxy of a panelist along with a galaxy of a moderator as well. And we would now invite Dr. D. Ramesh to set the context and start panel discussion. Over to you, Dr. D. Ramesh.
Yeah,
Yes,
Vijay
we
Kumar
have a
also
Dr.
joined, sir.
Dr. Vijay Kumar also with us. Yes, he has just joined. And I would like to introduce to you our galaxy of panelists, Dr. K. Vijay Kumar, who is the well-known diabetologist and having again the vast experience in the field of a diabetologist. So here we have, our Dr. D. Ramesh to set the context and start the panel discussion. Sir, over to you, sir.
Good evening, everybody. I am extremely sorry for the delay in starting this seminar. That too very late in the night. That too on Monday evening, which is a very busy day of the week. Uh, it's my great pleasure. At the outset, I must thank Mr. Santosh and Swati for giving me an opportunity to moderate a very important, uh, what should I say, a webinar on statins. And I think the statins has been the drug of miracle and has been there for a very long time and encompassing almost all the specialities and disciplines. It's an interdisciplinary drug. The question is, everybody knows about statin and they know when to use it, but there are certain things which we learn from our expert panel: when to use it, where to use it, how to use it, and what are the guidelines to say that. Because this is the one aspect where statin can be, if it's not used in the right direction, right proportion, right patient, it can be disastrous. At the same time, you may be denying the benefits that can accrue from using the statin. So before we start jump in, let me give a few introduction about the statins. And I would request all the learned speakers to introduce themselves so that they will be familiar to the participant.
Hi, this is Dr. Suman. I'm a diabetologist. Right now, I'm having an experience of 20 years in the field of diabetes, and I've got my own center called as Madhumeha. I'm also been chairman-elect for CARES DI. This is the coming year. I'll be the chairman for that. So, thank you.
Dr. Sandeep?
Hi, I'm Dr. Sudeep.
Sudeep,
I'm an endocrinologist currently working at Apollo Hospital, Jayanagar, and I have a clinic in Baswannudi called White Lotus Healthcare.
Dr. Vijay Kumar, please. Vijay Kumar.
Vijay. I think he's muted. Vijay? You're muted.
You're not only muted, you put on the mask. I don't think you will be audible.
Sir, now you're audible.
Yeah. A filtered voice. A clean and a filtered voice.
Thank you, sir. Thank you. Sorry.
Sorry.
I am sitting in the OPD only.
Oh, I'm sorry. So go ahead.
Yeah, myself, Vijay Kumar. I'm a physician and diabetologist practicing at Greenview Medical Center and Narayana Medical Center in Longford Road. Myself, recently I was in the organizer for the Karnataka RSSDI 2020 in November, which concluded very well. Nothing much to say. I think we should go ahead with the program. We are already late. I actually logged in very late. Sorry for that.
Okay. We will finish it off quickly, sir. Dr. Chandrasekhar, I think, will be joining us very, very shortly. So before I set the tone for today's webinar, let's. I have got a few things. One minute. Is it visible? Hello?
No, sir.
Is it visible?
No.
No. Okay.
No.
I think you should share your screen first.
Amrish, can you please help to Dr. D. Ramesh?
Oh, wait.
Doctor, in the footer, can you see the share screen button?
Yeah.
Click on that.
Yeah.
Once you will click on that, select what screen you wanted to share, and then click on the share button.
Okay.
Sir, have you clicked on the screen? Share screen? One pop-up will come.
Okay. No. My slide is somewhere. It's hidden now. 1 minute, please. Just a minute. Somewhere.
So I think you would have minimized it. It will be down on the screen bar, down.
It's there.
If you click on that, it will open up. But first you need to share your screen, sir. Your screen is not shared.
Okay. I'll share the screen.
Yeah. First share the screen and then open that.
No. Yeah. Share. Where is it?
Sir, in the footer, can you see the share screen option?
Green color button is there.
Green color button is there.
Yeah. But the problem is that slide. Yeah, it's there. Yeah. I got it now. Now is it visible?
Yes, sir.
Yes, sir. Visible, sir.
Okay. So this before they say this ischemic heart disease or whatever is atherosclerosis is a misfortune that comes by the door that has been left open, and And everybody knows that in 2011, they said one of the leading cause of death is dyslipidemia. And I think by 2020, we have become the diabetic capital, ischemic capital of the world. And the coronary artery disease, I think, is more 3 or 4 times more than the American, 6 times more than the Chinese, and 20 times more than the Japanese. So I think all of you are aware. So about 40% of the patients of ischemic heart disease in India are below the age of 45 years of age. Now the facts of this is there's already many people have asked the question whether there's a direct link between the dyslipidemia and ischemic heart disease. Yes, as per the Fleming-Hart study and Mr. Fitz study, there's a direct correlation between the cholesterol and coronary artery disease. So there's a continuous graded association with cholesterol and the risk of ischemic heart disease starting beyond 180 milligrams. So less than 180 milligram of LDL at that particular point of time, there is no risk factor. Above more than 180, cholesterol is more. But the most important landmark study that has come into vogue is the Intro study, where they have shown that it is out of the 9 risk factors, the lipids constitute the most important coronary risk factor. So because of this, I think the dyslipidemia has caught the fancy and the focus of all the physicians, cardiologists, diabetologists, and clinicians. So now it has been proved beyond doubt that dyslipidemia is a major risk factor of coronary heart disease. Now the question arises, which should we target? Should we target HDL, LDL, or VLDL, or chylomicrons, or the triglyceride-rich particles? But as per the guidelines, it says that LDL should be the primary target for the management of dyslipidemia, that is class 1 indications, and non-HDL should be class 2A indications. So till present day, I think one should always concentrate on primary LDL and not non-HDL. And statins are proved it's a miracle drug. And all of you know the statins that are available. The only statins that are available in the market right now: rosuvastatin, atorvastatin. Simvastatin is a drug available in USA. Lovastatin, pravastatin, servastatin have been out of market. So everybody knows that benefits of statin. It lowers the cholesterol by more, lowering LDL. High intensity statin lowers the cholesterol by 50%, moderate intensity by more than 30 to 50%, and it reduces the atherosclerosis coronary vascular disease across the spectrum of baseline LDL more than 70. So absolute reduction in acute atherosclerosis coronary vascular disease is proportional to the baseline of the absolute risk. So higher the LDL, greater is the risk reduction when you use statins in right proportion. So statin therapy for increased reduction. Apart from reduction of LDL and coronary artery disease, it has got a pleiotropic effect like anti-inflammatory, antioxidant, plaque stabilization, antiplatelet, and anti-proliferative. Now the question that I would like to put to the panelists, so I wouldn't say the question, we would discuss like this: which group of patients would benefit from the statin therapy? I'm not asking this evidence. I would like to know from your experience, so that the experience which is ambient to our delegates who are also got the same down. Which group of the patients? So Suman?
Yes, sir. Generally, what happens is
before I start, I would like to make things clear. This is not dietetic or testing anybody's knowledge or not. We are sharing our experience. That's all. We may be right, we may be wrong. So if there's right, if you are wrong, we'll correct it here so that we'll have a correct perspective of use of statin. Okay. With that respect, yeah.
Yes. I think probably we have a lot of...
Your face is... sorry, Suman sir. Ramesh sir, your face is not clear. You can just, little down your laptop.
Yeah.
Screen.
Okay.
Yeah, thank you, sir. Sorry, Suman sir, carry on, sir, please.
No problem. After. In fact, we have a lot of guidelines which really says that ESCT guidelines or ESC guidelines, everything really says that cardiac prevention. We say that the most aggressive statin therapy has to be started off for the people who have got a high cardiac risk. Not only high cardiac risk, probably who have got an established cardiovascular diseases also has to be kept in mind. We also say that type 1 diabetics or type 2 diabetics probably with a target organ damage. In fact, they are also one of the most major people who require the statin therapies. And when we look at this, risk stratification, we say that, the people who have got cardiac kidney failures, all those things are also, more intent towards, taking a statin therapy. Also, peripheral vascular disease, we call it as, the circulation problems for them having a PVD kind of a thing. They are also, intent to take a statin therapy. This is what I feel is required for the set of populations.
Dr. Sandeep?
Sudeep. Yeah.
Sudeep.
Yeah, so it's whether it's primary prevention or secondary prevention. Secondary prevention, there's no doubt, so everyone should be on statins, whatever established vascular disease. In primary prevention, I would see, anyone more than 40, I would, any risk factors, smoking, any other risk factors, I would probably give him a statin. Even otherwise, I don't know, it may be a bit controversial. I feel everyone who's more than 40 should be on a statin, especially, with you just telling that, all our patients, ischemic heart disease is less than 45 for most of our patients. So we should probably consider statins as a general thing for majority of our patients. And younger than 40, if they have risk factors, I would probably consider a statin.
Dr. Vijay Kumar, please. Hello?
I think he's off, sir.
Vijay Kumar?
Yes, sir. I agree with Dr. Suman and Dr. Gupta. See, in my clinic, what I regularly see is there is one set of people basically who have a very bad lifestyle. Even younger people who is having a very bad lifestyle, they come with a higher LDL cholesterol. Even though they are not having diabetes, we can definitely foresee that they will be developing diabetes because they have a family history. They have a very poor lifestyle and very, very, very poor diet habits. So such people definitely we need to advise on doing the lifestyle modifications. Even after advising, they are unable to do the lifestyle modifications. 3 times repeatedly, they come with a lipid cholesterol profile. Every time we see the LDL is very high. So I think these people are definitely those who are going to get into a cardiovascular risk in the future. We need to properly look at these people, convince them and start them on a low dose, at least low intensity statins started early in the setting definitely can prevent the progression into the cardiovascular risk. Once they develop any diabetes or any other comorbidities, they are definitely on the primary prevention mode. So this is what my first thing when I see into my patients.
Okay. Thank you very much, Dr. Vijay Kumar. Dr. Chandrasekhar, please. Has he joined? Hello?
No, not yet, sir. Not yet, sir.
Oh, okay. So let's see what the evidence say. So who are to be benefited by statin? Actually, there are 4 statin benefit group. Individuals with clinical atherosclerotic coronary artery disease. That means individuals with coronary artery disease, as pointed out by many of all the 3 speakers. Individuals with primary elevation of LDL more than 190 milligrams per deciliter. Individuals with 40 to 75 years of age with diabetes and the LDL less than between 70 to 110. Between 40 to 75 years age with LDL less than 70 are estimated the 10-year risk of 7.5%. So these are the 4 individuals who really require statin. One is coronary artery disease. Second one is primary prevention, whose LDL is, as Vijay Kumar pointed out, whose LDL is more than 190. And in diabetic patients within 40 to 75 years without any clinical evidence of ischemic heart disease, or individuals without ischemic heart disease or diabetes who are in the age group of 40 to 75 with the LDL between 70 to 189, provided their estimated 10-year risk is more than 7.5%. So this is what the evidence says. So shall we move to the second question?
Yes, sir.
Which intensity of statin for which type of patients? So there are 3 types of intensity. One is high intensity, moderate intensity, low intensity. High intensity statins are those which are which reduces approximately more than 50% of LDL on average of the baseline, moderate between 30 to 50% of LDL of the baseline, and low intensity is more or less than 30%. For all practical purposes, clinically we don't use low intensity LDL. I know many of the physicians, family physicians and clinicians use 5 milligrams and 10 milligram those statins. I think as per the data, they are of no benefit. It's just like giving a placebo. So more than anything, I think either you should use a moderate intensity therapy, the intensity therapy or high intensity therapy. So I would like to learn from the speakers, panelists, where would they would like to use high intensity therapy and a moderate intensity therapy.
Sir, I would say that high intensity therapy, wherein probably the LDL is more than say around 190, as you rightly pointed out, where we want to really reduce down, because we say that we are looking for a value of something around 70 to 90 is what we feel is the right ideal choice. So in those cases where we feel it is very high, we definitely have to use a high intensity statin. Okay. And at moderate intensity, I would say that around 30 to 40%, maybe around 120, 130 people. I think those cases we just want to start out on a moderate intensity. That's what I feel.
Okay. Next one, Dr. Vijay Kumar.
Yes, sir. Sir, those who are having these comorbidities like diabetes or hypertension, these people are definitely under metabolic stress. Any metabolic stress coupled with this LDL, high LDL, they are going to end up in a big cardiovascular adverse outcomes. So I think all such patients who are having any other comorbidities, definitely we have to start on high intensity. Those who don't have any comorbidities and they have very high risk of developing any of the metabolic problems, we better start with a moderate intensity in the intention of a primary prevention or early prevention mechanism. So these are the two things which I would generally think, sir.
Dr. Sandeep?
So as Dr. Vijay was saying, I would go, in my practice, I always use a moderate intensity statin for most of my diabetes patients as primary prevention. But if it was secondary prevention, so this established vascular disease, then I would generally go for a high intensity statin, aiming for at least more than 50% reduction in pre-treatment LDL. Even though they might have an LDL of only 100, but I would aim for LDL of 50 in such patients. So I go for a high intensity statin in that.
Why this question has been brought up is most of the clinicians, especially family physician, are confused between high intensity and moderate intensity, and they feel that higher the intensity of therapy, greater is the risk of the adverse effects. So so we thought this would be an ideal question to be answered. I think all the three panelists have answered very well. Let's see what the data says. See, in the role of in acute coronary syndrome, we use statin because most of the coronary artery disease not only due to atherosclerosis, it's also due to inflammatory markers. So that is because CRP. When higher the CRP, greater is the incidence of coronary artery disease. So statins are used to reduce the inflammatory markers, which reduces it. So the potential, because where statins act rapidly and favor is it improves the endothelial integrity, decreases the plaque matrix, reduces plaque inflammation, and decreases the reperfusion injury. So what are the landmark trials? See, if in acute coronary syndrome, if you look at the landmark trial like Armada ACS, acute coronary syndrome Armada, higher the 80 milligrams of statin reduce the acute coronary incidence almost by 17%. Even in the recapture, Armada capture, so you're loading 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin before PCI. I think it reduced the incidence of acute coronary syndrome by almost by the 20 to 25%. So the coronary events in acute coronary syndrome, when you use statin, is reduced dramatically when you use high dose statins. And what about in a patient with stable stable coronary artery disease? Again, the Armada capture has again shown that the patients who are undergoing PCI definitely benefit when you use high dose statins like 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin. Even in stable ischemic heart disease, high dose of statin is a very effective for CV protection in stable ischemic heart disease. So intensive therapy with 80 milligram or a 40 high intensity statin reduces by the especially pravastatin by 33%, in other words death and MACE by 16%. So aggressive lipid lowering of 80 milligram of atorvastatin and 40 milligram rosuvastatin in acute coronary syndrome has been shown to reduce morbidity and mortality to a very great extent and has benefited the patient, as evidence based in acute coronary syndrome like Miracle trial, Prove It, TIMI 222, Ideal and Regress. And when you are doing a procedure, angioplasty, Armida, ACS, Armida recapture and Naples. So the data is strongly in evidence that high intensity of statin, 40 milligrams of atorvastatin or 24 or rosuvastatin 80 milligrams would definitely benefit the patient when used in these particular situations in acute coronary syndromes and during PCI procedure. So the benefit of intensive statin therapy is evidenced in who underwent PCI. Is most probably it's due to pleiotropic effect, significant better myocardial perfusion with 80 milligram atorvastatin or 40 milligram rosuvastatin, proven efficacy in long term, absence of form. So this is the evidence that says that high intensity of atorvastatin should be used in acute coronary syndrome and in procedure. And people are wondering whether high intensity of statin would definitely cause side effects. No. So they say that as per the American Heart Association and Circulation 2007 and 2008, way back they've shown that 80 milligram of atorvastatin is safer than 81 milligram of aspirin. So one should not be scared of using high intensity statin when it is warranted. No side effects have been visualized. Now, in the present circumstances, statins are also used in COVID-19, especially in a retrospective study from Hubei, China, where 13,981 patients were treated with atorvastatin. They found that the incidence of mortality and morbidity was reduced to a greater extent when statins was used. Why statins was used in COVID? Because COVID is an inflammatory disease and statin also acts on the inflammatory markers. Therefore, by indirectly reducing inflammatory markers, it benefits patients in COVID patients with or without coronary artery. So COVID patient with or without coronary artery disease do benefit with atorvastatin. So the next question that comes is, every diabetic should receive statin regardless of baseline LDL level. So I would request the panelists to give you their opinion, please. Their thoughts on this.
Yes, sir, definitely I agree. Definitely I agree. Every diabetic should be receiving statin, and because the guidelines also says the LDL level should be below 70 for any coronary vascular prevention. So I don't think anybody will be having less than 70. So all diabetics. Moreover, LDL is the one of the key the ingredient that is very commonly seen with diabetic. The diabetic dyslipidemia is again linked to the LDL itself. So I think we need to put in a moderate to high intensity statins for every diabetic, basically as a prevention, primary prevention.
Dr. Sudeep?
Yes, sir. So diabetes is itself as a cardiac equivalent. So everyone should be on a statin, and it's so challenging to improve patients' blood sugar control. It's so challenging to make people change their lifestyle. And if giving them a pill which is so safe reduces their cardiovascular risk, I think it's certainly one thing we should encourage everyone to use a statin in all their diabetes patients and also their pre-diabetes patients too. I would strongly encourage everyone to use a statin on their diabetes patients.
Dr. Suman?
Well, slightly, I have got a slightly different view. I feel that, starting a statin for a freshly detected diabetic might not be of greater help. Maybe we are really, looking for all the parameters. For example, we're looking for the family history, we're looking for other data, having all those data and probably, seeing that, and if at all, if the person is falling into the risk category, only then we start a statin. If not, at least, for 4-5 years, I would say that I would definitely not start on a statin for a newly detected diabetic. I mean, newly detected, clearly newly detected, not means that, is not checked it for a long time and has become diabetic, nothing like that. But for a newly detected and his sugars are well controlled, I would say that I will better not to use statin, just hold on for some more days. That's what I feel.
Okay. So let's see what the scientific data say. So major statin prevention trials, especially CARDS, have shown that it reduces 37% reduction when you use atorvastatin in a patient with diabetic patients. So usually, normally with primary prevention and secondary prevention, you see that with diabetic patients, when they use statin, it reduces the morbidity and mortality to a greater extent. I'm sorry. Okay. So cards and Ascot LA cards have shown that there is almost a 23 to 37 and 33% reduction in the use of in the cardiovascular morbidity mortality when statins have been used in diabetic patients. My important question now is, why is that in the guidelines they say that you should use statin only after the age of 40 years, not less than 40 years? Because in India, it's a decade earlier or almost 10 to 15 earlier they develop diabetes. Say a 20-year-old diabetic patient or a 25-year-old diabetic patient is denied of statin if you go by the guidelines which says that you should start using statin only when they're over the age of 40, 45. Your thoughts, please? Suman?
Well, sir, I would say that, we'll have to really look in for the risk stratification, what we call it as, less than 7.5 and the age factor is less than 40 years. I would better not start on a statin, actually. That's what I feel. Maybe if at all, if the risk scores are more than 7.5 and probably the age factor is between 40 to 70, I definitely would like to start and then definitely on a high intensity. That's what I feel.
Okay. Dr. Sudeep?
Sir, I usually would offer a statin to a patient. So if it's a man, no issues, no pregnancy on there. So I just offer them. If they are agreeable, I just start them at whatever age they come. If it's a lady, I suppose I would, if there's no plans for pregnancy, which is always a difficult thing in a childbearing lady, I assess the risk and consider, but I would certainly, this is something I discuss and offer. Okay. There are many people who agree to go on a statin and I start, even if it's a 25-year-old.
Okay. Dr. Vijay Kumar?
Sir, as you rightly said, Indians, we are having both diabetes and dyslipidemia at 10 years earlier compared to the global age statistics. And when there is an evidence that, primary prevention has reduced cardiovascular outcomes by early initiation, so why not start early, sir? Okay. So we definitely have to start those with diabetic even earlier with statins. I don't think there is any harm and it has been proven.
So this is an important question because many of the clinicians and primary family physicians are really in a fix whether to start statin when they see a diabetic patient less than 40 years. Because if you go by the guidelines, you should start only after the age of 40 years. And most of the Indians do not fall into that group. So I had a discussion with one of the very popular endocrinologists across the other two places, one is USA and this one. They say that it's because of why they have prescribed statin after the age of 40 years as per the Western standard is, they say because of this legacy effects, they say that macrovascular complications arises more than above 40 years and microvascular complications occurs before 40 years. So they felt that, in order to protect a patient with coronary artery disease, better to start after the age of 40 years. That is their thoughts, but the evidence, I don't know what the evidence. I think the endocrinologist and the diabetologist should enlighten about this. And in my view, in my perspective, we see that if you see a diabetic, irrespective of the age, I think you should start statin because as a cardiologist, I've seen patients, younger patients with 28 years, 32 years, or 35 years of diabetes having a frank coronary artery disease just because they are not started on statin. They just control that blood sugar, but nobody told them that the statin should be started. So I think we'll better to err on the safer side. So I would, like Sudeep said, I would, if I see a young patient with 22 years with a diabetes, I would like to start statin. for whatever it is. And the side effects of starting statin is already proved beyond doubt that it does not affect the adverse effects as we imagined. What do you say?
Correct, sir.
We'll go by you, sir.
I agree with
Sudeep.
you, sir. When they say after 40 years these microvascular or macrovascular complications start, but diabetes itself is leading to microvascular or macrovascular complications depending on the severity of the hyperglycemia. So it can be before 40 years also. Why 8 till 40 years?
No, another thing is it occurs 10 to 15 years earlier than the Western standard.
And
So
yes,
if you
we
go
are
that,
also 10 years earlier.
if you go by that, I think we should start when. So there's a saying that there was a saying that apple a day keeps a doctor away. A statin a day keeps a heart attack away or a cardiologist away. So you have come to a substance. If you look at the Jupiter trial now, even a young person over the age of 55 years without any risk factors, if you take a statin, I think it reduces the coronary arteries by almost 45% and morbidity by 48%. So in abroad, it is sold over the counter for a primary prevention. So you and me can take statin. You don't have to wait for diabetes to occur. You don't have to have other risk factors to set comorbid condition to set in to start the statin. So this is my personal opinion, and I felt that. And another thing you should note that it is criminal negligence if you don't prescribe statin in Western world. If the patient after the age of 55 years ask for a statin, I'll tell you, this Jupiter trial has shown that after the age of
Yes, sir.
55 years, without any comorbid conditions like hypertension, diabetes, smoking, family history, dyslipidemia, in spite of in the absence of that, if you prescribe statin, it over a period of 5 to 10 years, they've shown that the mortality comes down by almost 45%. Coronary artery disease comes by 45%. I know you may not agree with me, but this is my personal opinion, and I would like to start this statin. In fact, there was a saying that just like iodinization of the salt, because to keep the hypothyroidism away, they wanted to do the statinization of the water so that they can prevent the coronary arteries in the height, especially it's required in Indian subset, because we are already the coronary capital of the world. Now, this is on the lighter side, I'm telling you, that's
Yes.
possible. Okay, we'll go to the next question. Statins from primary and secondary preventions. In 2 or 3 sentences, Dr. Suman?
Well, sir, I would say that primary and secondary prevention, I would definitely use it as start of a statin. It could be something like, Jupiter trial clearly told that, rosuvastatin can be used, whether, trying to reduce the LDL or trying to primary prevention. Definitely, we just wanted to use that. When we look at the secondary prevention, I would say that, cardiovascular mortality is very high in people who have got major complications, major CV events, what we call. So in those cases, probably when we are trying to use this, definitely it brings down a lot of, comorbid means a lot of mortality. So I would say that better to use primary as well as secondary prevention. Definitely it can be used.
Yes. Sudeep?
Secondary prevention, definitely yes. Primary prevention, diabetes, definitely yes. Primary prevention, otherwise in a healthy man, I would probably, I would not push the patient, but I would say this is something you could consider. So otherwise, if it is diabetes, I would definitely push the patient to be on a statin. Otherwise, I know I sit on the fence, I leave the choice to the patient.
Vijay Kumar, please.
Yes, sir. Secondary prevention, definitely we don't have to think of it. Primary prevention, we can select our patients. Definitely, like if a person is aged, even if there is no comorbidities, definitely statins will help. And if the patient is young and has got a very bad lifestyle, and if we can see properly that he's going to have a coronary risk, why not start him on primary prevention as well?
So in my experience, in my practice, if I find a young individual less than 50 years who has got a family history of coronary artery disease, but he doesn't have coronary disease, no comorbid, say 20, 25 years, both parents or one of the parents have got coronary disease or one has had a severe cardiac event, I would suggest to that particular person, the incident, just son or a daughter, to take statin, primarily because to prevent a coronary event. Though Jupiter trial says it should be given over the age of 55 years, I do take into consideration, as someone said, that we have to look at the comorbid conditions also. A strong family history is sufficient enough to, I think, to start statin. In this regard, I had prescribed a statin to a 28-year-old software engineer that both his parents, one of his father died of ischemic heart disease, mother had angioplasty, brother had a stable angina. So I told him, you have to take statin, though he had all the echo, ECG, TMT negative, and he said yes, okay, but only one question: does it affect my potency? What if I become impotent? That was the question he asked me. Any thoughts?
Um,
Should
if
not be,
it
sir.
were to, if stat, should not be. Yeah, it might actually improve his potencies.
Yeah, right. See, the one of the cause for impotency is atherosclerosis
Yes.
of penile artery. There are so many studies done, and they are done even angioplasty for penile artery. So this statin do definitely reduce atherosclerosis. So it should not be a cause. So I had to tell him. So he's taking statins now. No, because why I'm telling is these are some questions. This is not given anywhere in the book or anything. I think we need to get it only by discussion, interaction. We can't do so. I think statin is safe.
Very interesting, sir. Why did he ask that question, by the way?
Because he is more, see, he says I don't have any problem, but you think I may develop heart attack. But what if I take that and if it affects my potency? I'm getting married shortly. See, these software engineers now, software they
Hidden
come,
fear.
IT
Hidden
people
fear
now.
discussed only with doctors, sir.
IT people no, they have got three doctors. One is Google doctor, other is neighbor doctor, other one is the Google, other is a family doctor. So they would like to more rely on Google doctor than anything. So they read all the side effects first, then they come. So that's it. Okay, let's see what the study says. So for the primary prevention, we can use with the patients without any coronary artery disease, atherosclerosis coronary artery disease, especially when you have LDL between 70 to 189. If you have to calculate what is known as 10-year risk factor estimate. If it's more than 7.5%, so one should use the moderate intensity therapies or 1A. If it is between 5 to 7.5%, then you would moderate intensity therapy. So in diabetic, there's no question answered. So here also they say between 40 to 75%. One should 40 to 75, 1A, class 1A indicator, moderate intensity statin or high intensity statin when the ACV risk stratification is more than, that's 2AB. So if it is less than 40 years and more than 75 years, you say, then you have to balance between the coronary benefit and the adverse effect to use. So as per the American and Diabetic Association, European Association, they say use of statin below 40 years in diabetic patients and above age of 75 years should be the discretion of the treating physician. But in India, I think we don't know where we stand. So what are some of the clinical trials for secondary prevention? You have got the Pruvit-Temi, atorvastatin, and pravastatin. So there are so many things. So all the patients with secondary preventions are those who have had an coronary artery event and were likely to develop another event. In such a situation, use statin to prevent that. So with no controversy, I think in secondary prevention, statin should be used. People were asking whether high dose of statin have adverse effect. If you look at these so many clinical trials like Pruvit, A to Z, TNT, IDL, and Sparkle, you see that the standard dose and high dose. Standard dose is 10 milligram, high dose is 80 milligram, 40 to 80 milligram. You see that the adverse effect is almost nil. It's comparable to standard dose, 0.55. Sparkle is atherosclerosis in carotid artery. Ideal, see, you can see that. So one can safely say that you can remove it from your mind that high dose of statin or a moderate dose of statin and using it for a longer period causes adverse effect. Definitely it should not. So now we come to the guidelines, the last part. What does the guidelines say? So in secondary prevention of patient with very high risk of LDL, more than 50% of the baseline, and LDL goal of less than 55, it is a class 1A indication. So in a primary prevention for individuals very high risk but without familial hypercholesteremia and LDL reduction more than 50%, I think you should use high risk to, that is 1C. So one should not use in a patient in a moderate risk, LDL less than 100 should be considered, and in individuals low risk, I think the goal should be less than 110. So this should be the consideration. So one should remember that the patients with high risk and moderate risk, the statin should be prescribed as per the guidelines, and statin should not be discarded because it causes side effects. So high incidence of coronary disease in India is due to multi-risk factors and unhealthy lifestyle. Dyslipidemia is always a major risk factor for CVD. Statins are considered as first-line therapy for primary and secondary prevention. And both rosuvastatin and atorvastatin have got the treatment, the same clinical trials proving their benefit. So I think we come to the end of the day. And before we close, your final thoughts, all of panelists, please.
Well, I would say that statins are definitely important, either be it primary prevention or secondary prevention. But, just go by the saying, always try and use a statin and definitely can achieve a good target. That's what I always.
Dr. Sudeep?
Sir, as we went through the slides, all guidelines, all data, everything shows that statin has to be used. But in real practice, we see very few statins being prescribed. So I would say encourage all doctors to prescribe a statin or at least consider statin if it's a low risk patient.
Okay. Dr. Vijay Kumar, please.
Yes, sir. I think the only major issue that is stopping many of the physicians to start statin is the pill burden. Many people think that at this age only starting on a tablet and taking it lifelong is going to be a bad thing, and they start cursing the doctor itself. That's not necessarily they're giving the tablets. So I think that is one thing that is stopping many physicians from not giving the statins. But whatever said and done, we have known, and then there is a lot of evidence that starting statin is 100% beneficial in terms of cardiovascular risk. So we should be starting on a statin. Somehow convince and start.
Yeah. Now the other two aspects that statins are shown benefit in patients with isolated atrial fibrillation. And the second one is in CKD, severe CKD diseases. I think statin using reduces the mortality and morbidity by coronary event, because in CKD, the death is not due to CKD per se. It is due to the coronary artery disease. I think statin should do it.
Yes,
we are ready to take questions from the participants, and our panelists are there. Dr. Santosh? Mr.
Yes,
Santosh?
sir. Just checking out, sir. Checking out. Yes.
Anything in this one? Question box?
Sir, I think you can stop sharing so that
Okay, right.
Sir, I think most of because there is no question till now, sir.
Okay.
Because I think little clear, I think so, sir, because the topic, and it will be very clear, because usually what we will see, sir, because many of the questions will come in between, and here more than 50 through 53 doctors are there in this one as the audience. So just I will hand it over to Swati ma'am. Swati ma'am.
Before I hand over, I think I would like to congratulate and thank all my panelists and colleagues for doing a wonderful, giving a wonderful talk on their thoughts and sharing their clinical experience. In fact, I learned more from you people, and I think I'm more enlightened now from your interaction and discussion with you. Thank you very much, speakers.
No, we should thank you, sir. You as a moderator, you really moderated so well. You are trying to balance out each one of us. And in fact, Vijay Kumar, in spite of his busy practice, he was there to support us also. Thank you, Vijay.
No, Suman, thank you, Suman. Thank you. Sir, we all being diabetologists and endocrinologists, you being a cardiologist, we needed more explanation from your side to guide us more of using the statins. Yes. Thank you, sir.
Thank you. Over to Swati and Santosh.
Yes, sir.
Sudeep, you have got anything to tell? You are the one who are not.
No, sir. I just wanted to thank you, sir.
Okay, thank you.
Yeah, thank you all, doctors.
Especially, sir, Sudeep sir is always silent and is very keen about this, the point which you have spoken about, sir. Okay. So, thank you, Sudeep sir and Suman sir, Vijay sir. Yeah, Swati ma'am, can you please vote up?
Right. Yeah, sure. So we take this opportunity to thank Dr. D. Ramesh for moderating this panel discussion, and all the panelists, all the eminent panelists who are there for sharing their experience of statins and rosuvastatin in clinical practices. We would also thank all the doctors who have joined us for panel discussion. I'm sure that you will appreciate the galaxy of experiences present today. So we salute all our doctors, paramedics who have contributed immensely for keeping us all safe and healthy in this challenging and pandemic times. So we at Alchem Lab will contribute to serve doctors and patients by making our product available, especially our chronic brands, Jupiros, Gluvilda M and Olcane. So thanks once again, Dr. Ramesh sir, Dr. Suman Ramchandra, Dr. Sudeep Puttamano, Dr. Vijay Kumar, for presenting this galaxy of experiences, to all the audience. Thanks a lot, sir.
Thank you.
Good night.
Sir,
Thank you.
thank you
Good
so
night.
much, sir. Thank you
Thank
so much.
Thank you,
Good night,
sir.
sir. And be
Good night,
safe,
sir.
sir. Sir, be safe.
Okay,
Hope the
okay.
dinner reaches our home.
Yeah,
Parcel
yeah, yeah.
dinner.
Okay, right. Thank you.
Thank you, sir.
Thank you, sir. Thanks a lot. Bye, sir.
Bye.
Bye.